this is being held unhappily due to the conditions with COVID-19. This is being held in Zoom. However, I hope that in the future we will be having in-person meetings again, inshallah. Today, we are convened to address the complex issue and of interaction between the COVID-19 pandemic and the use of antimicrobials, which in itself was already becoming a major problem in the past with the emergence of multiply resistant bacteria all over the world. As I'm sure you know, this is not a new issue. Antimicrobial resistance, it appeared very quickly after the discovery of penicillin. And since that time, we have been having major problems with whenever we use an antibiotic, bring it on the market, very quickly within a period of at most a few years, 2-3 years, emergence of resistant bacteria happens. And unhappily, because of the fact that we are not catching up by introducing new antimicrobials, this is becoming a major issue in public health and for the clinicians as well. Sadly, of course, we now have another complex issue, and that is the outbreak of the pandemic with COVID-19. COVID-19 for the clinician poses a major problem in the sense that they feel that they have to take care of patients in the best manner they can. This is a viral illness, but oftentimes, even though it's a viral illness, we are faced with people who are sick, who may have pneumonia, and oftentimes the temptation is great to introduce the use of antibiotics. So that said, this is being addressed in a big way now by our very eminent speakers. And we have 2 speakers who will be joining us. Each will be speaking for 20 minutes. And then we will be having a group of panelists, very distinguished panelists, who will discuss the subject as well. Our first speaker is going to be Professor Souha Kanj, who is a professor at the American University of Beirut. She's an infectious disease and internal medicine professor, and she will be talking about the subject of antimicrobials and antibiotic resistance in the Arab world. Dr. Souha.
Thank you. Good evening, good morning, everyone, wherever you are. It's a pleasure and an honor to be participating in this webinar. And as Professor Najwa mentioned, we'll be talking about antimicrobial resistance and COVID-19. And I thank Professor Najwa for her kind introduction. Okay, let's see. These are my disclosures. None are pertinent to today's presentation, and this is the outline of my presentation. I think it's no surprise to all of you that many analyses have been done to estimate the burden of antimicrobial resistance. And in this report by Jim O'Neill, he estimated that by 2050, 10 million people will die annually from antimicrobial resistance. And if we look at the map on the right side, most of these are going to be in Asia and Africa. And if we compare that, the 10 million annual deaths to the COVID-19 pandemic that has killed 1 million people so far, we can see that a lot of efforts have been put on COVID-19 and not as much effort have been put on AMR. Now let's look at the consumption of antibiotics by country. This is a report in 2015 that looked at the defined daily doses of antibiotic per 1,000 inhabitants per day. And they divided the countries into high income, upper middle income, and lower income. And if you see here in examples for countries in the region, United Arab Emirates and Lebanon, one from a high income country, the second one was in the upper middle. Now I think we're in the lower income country, but we are among the big consumers of antibiotics. On the other side, if we look at Jordan and Kuwait in 2015, they were among the countries that consume less antibiotics. A couple of years ago, we looked at the epidemiology of resistant bacterial pathogens in the countries of the Arab League. And it was a bit difficult to put this data together because there were many limitations. And more recently, in an effort to put some guidelines for treatment of multiple multi-drug resistant gram-negative pathogens, we looked at updated data. And if we look on this map on the right side, and as you see, the rates of some of the pathogens, such as carbapenem-resistant Acinetobacter baumannii, for example, in most countries of the Arab world is above 70%. And as we were collecting the data, we realized that there's lack of standardized national data for most countries, and there was a lot of variability in techniques used in interpreting susceptibility, in the choice of invasive versus non-invasive versus pool laboratory data. So it was like comparing apples and oranges in some situations. Now, if we ask ourselves the questions, why our countries in the region are at increased risk for multi-drug resistant, and the reasons are very well known to most of you. As you know, they have rapidly developing links with the world, heavy travel, particularly to countries such as Saudi Arabia for Hajj, for Umrah, or United Arab Emirates for various reasons, winter holiday destination in some of the countries such as Lebanon. And the Arab countries have a unique population structure with a very high rate of expatriate population. Some of them come from countries with high rates of resistance, such as Southeast Asia. And also there are many countries in the region that have lack of regulation on their antibiotic disposal and very weak infection control practices. And not to ignore the fact that wars and conflict have played a major role in spreading antimicrobial resistance. This was an editorial in Lancet published last year, and it talks about how AMR in the Middle East is a perfect storm. And they speak about the lack of data on AMR, which makes it really difficult to compare the Middle East to the rest of the world. This is from data collected recently from Syria, and prior to that, there was really very little published data from Syria. Aula Abara's group, who is in the UK, we tried to put together some resistance rates from Syria, and the rates were really very alarming. 20% carbapenem resistant E. coli, tigecycline that's heavily used for Acinetobacter, 64% of their isolates from collected from multiple labs in Syria were resistant, and even colistin resistance in E. coli and Klebsiella was high, reaching around 10%. This is a drug that we thought is a last resort agent to be used for extremely drug-resistant pathogens. And this is from the review that we published 2 years ago, and I don't mean to go over the details, but whether you look at Pseudomonas aeruginosa, Acinetobacter, or some of the gram-positive pathogens, very common pathogens such as Strep pneumo or Staph aureus, if you look at the resistance rate in the Arab countries, the darker the colors, the higher the resistance rate. And you could see that we have quite a bit of high resistance rate in many of these troublesome pathogens. Now, there was this report in the Lancet ID a few years back talking about antimicrobial resistance and the need for global solutions, because really when we talk about AMR, we shouldn't only focus at the human use of antibiotics. We need to think about the animal use, the food produce used, and all of these have been using antibiotics. And this is also contributing to the multi-drug resistant pathogens. And there is now a call to look at the AMR as a One Health approach, meaning looking at veterinary medicine, looking at agriculture medicine, as well as human medicine. This is from a recent report looking at how much do certain countries consume in terms of carbapenem antibiotics. And if we look at the standard unit per million population, and on the right side, you have Egypt over 5 years. And as you see, Egypt, for example, is a huge consumer of carbapenem, and that explains why we're seeing very high rate of carbapenem resistance in Egypt. This is a study that is in preparation that looked at an infectious disease working group survey in Arab country. It was a questionnaire that was sent to many critical care and ID doctors, and there was a set of questions asked to these doctors. And among the questions were, what is your preferred option for treatment of severe infection with extended spectrum beta-lactamase producers? And look, all the doctors said carbapenem. So despite the fact that we have many options available to us, we are still using and abusing drugs such as carbapenems that are contributing to resistance. This is from the WHO report on surveillance of antibiotic consumption. And if I compare two countries on this figure, Jordan, for example, that is a low consumer of antibiotics, as opposed to Sudan, look at the difference. And this is defined daily doses per 1,000 inhabitants per day. And also the type of antibiotics that are consumed. For example, in Sudan, there's a huge consumption of beta-lactam antibacterial. In Jordan, for example, more use of macrolide and lincosamide. Another study that was done very recently in 7 countries of the Arab world, and this is now in press for publication. It was a point prevalence study, a one-day point prevalence study looking at consumption of antibiotics and infections in hospitalized patients in acute care hospitals in 7 countries that are listed here. And as you see, 28% of the patients who were in these hospitals had infections. 98% of these 28% were receiving antimicrobial agents. So we are really heavily consuming antibiotics in our region. And if we look at, again, I take the example of carbapenems because they are among the broadest spectrum antibiotics, a huge consumption of carbapenem, not only in in hospital-acquired infection, but also in community-acquired infections that required hospitalization. But as I mentioned, it's not only in human. This is an example of a polar bear found to have resistant pathogens. We cannot ignore the wastewater treatment facilities that are hotspots for horizontal transfers of resistance. And this is a recent study from Kuwait looking at tetracycline residues in food products of animal origin and milk, and they found that the level far exceeded the allowed level. And not only in Kuwait, other studies from the Arab countries have looked at animal consumption in poultry and in agriculture, and how does this result in the emergence of multi-drug resistant pathogens, including a most alarming colistin-resistant pathogen. These are studies from Lebanon, but also other studies from Saudi Arabia and studies from Jordan that have assessed how much antibiotics we're using in farm animals have shown that we have alarming numbers. I think everyone knows that infection with multi-drug resistant pathogens contribute to increased morbidity, mortality, complication rate. Very importantly, the length of hospital stay and the cost of treatment is much higher. And with that in mind, societies have established stewardship strategies to help guide us in how to use our antibiotic therapy. And various antimicrobial stewardship programs really follow either all of the strategies or some of them to accomplish antimicrobial stewardship. Now, COVID-19 came to add fuel to the fire, I must say. As you know, now we have a huge number of infections throughout the world and around 1 million people who have died from COVID-19. But there has been a lot of antimicrobial overuse during the COVID pandemic. And Dawn Sievert said, since the emergence of COVID-19, collected data have shown an increasing antibiotic use, even though most of the initial symptoms are really from the viral infections. And I'm going to share with you some of the studies that have looked at what was the rate of bacterial co-infection in COVID-infected people, and what was the rate of antibiotic consumption in these patients. Now, all this stems from the idea that there was a concern that during the influenza epidemics in the past, there was around 11 to 35% of influenza hospitalized patients who ended up having bacterial infection, bacterial pneumonia. And because of that, people were very concerned that the same thing would happen with COVID. But a lot of the published studies now are showing that COVID-19 patients, the number of patients who have bacterial superinfections is lower than those who had influenza. This is, for example, a study looking at 4,000 adults. 21% of these patients received intravenous vancomycin within 48 hours of the presentation. Again, they were extrapolating the fear of the Staph aureus pneumonia, complicated influenza, to practice giving vancomycin to these patients. But 0.6% of these patients only had methicillin-resistant Staph aureus isolated. If we compare and contrast pneumonia following influenza to pneumonia following COVID, I think we are now collecting more evidence that with COVID, the pneumonia that's going to happen is going to be more late onset. On average, from the Chinese data, they occur 17 days after COVID, whereas with pneumonia with influenza typically appeared early on in the presentation. The pathogens in post-influenza pneumonia tended to be more likely Staph aureus, Strep pneumo. In COVID, we're seeing many more gram-negative pathogens. This is a table. I know it's not very clear to see, but just to tell you that there is a publication now in press looking at how many studies have looked at the percentage of co-infection with bacteria during COVID-19 and what is the percentage of antimicrobial use. And you see percentages such as 100%, 91, 99, 94% from various countries. And just here detailed few studies, again, to give you a flavor of what is the problem, what is the scope of the problem. 72% in this first study received antimicrobial therapy, only 6% had respiratory pathogens. Another study from the UK, only 3% had bacterial co-infection, majority received an antibiotic. And the last study from Michigan, 57% of their patients received empirical antibiotic and only 3% had documented community onset bacterial co-infection. And the alarming thing is that these received antibiotic on admission to the hospital, whereas as we see the evidence is suggesting that if the bacterial infection is going to happen with COVID, it's a late occurrence. Again, more study looking at global, this is in an ICU, 88 countries in Asia, Australasia, and the Middle East. 54% of the patients had suspected or bacterial infection, and 70% received at least one antibiotic. I think this is to keep in mind that these are ICU patients, as opposed to the studies that I shared with you earlier, that were more patients who came to the hospital, did not require ICU, and upon presentation, they gave them antibiotics. In a study looking at 16,000 patients who died of COVID-19, superinfection was seen really in a very small number of patients. This is also a study that is in press now, but the importance of the study is that it's a global meta-analysis, and it looked at antibiotic consumption for COVID co-infection. 72% of the patients received an antibiotic. Again, only 4.9% had acute bacterial co-infection, and only 16% had secondary bacterial infection throughout their course. This is from the same CID article from the US, and as I mentioned earlier, the majority of the organisms that are cultured from COVID-19 infected patients are gram-negative, and we have started to see some invasive fungal infections. Yet in practice, we are still seeing that physicians are jumping on giving coverage for gram-positive pathogens. Another thing that has contributed to the overuse and abuse of antibiotic during the COVID pandemic has been the telehealth medicine. A recent pediatric study demonstrated that overprescribing antibiotic is much more common in telehealth than in face-to-face visits. And biocidal agents as well are contributing to the emergence of resistance, and we have to be careful about how we use these. Now, why do physicians jump on giving antibiotic? I think most of the cases is just the standard reflex, because cough, fever, and radiographic infiltrates are usually thought of a pneumonia. And so people equate pneumonia with antibiotic, and a lot of physicians are very anxious and uncertain about what to do, especially that we still so far don't have final data on definitive proven efficacy of antiviral agent, despite the fact that remdesivir shows very promising results. Why do we worry about overprescription of antibiotic? It's not only to think about antimicrobial resistance. Excess use and abuse of antibiotics can increase the risk of Clostridium difficile colitis, which is a major problem now, and we're seeing a lot of relapses in these patients. The global supply chain of valuable medicine is decreasing, so we really need to preserve these particularly broad spectrum antibiotic for the patients who need them. There's increased nursing workload and a lot of unintended side effects of antibiotic, not just AMR, but cardiac, kidney toxicities, etc. And also during the COVID pandemic, there are a lot of resources for antimicrobial resistance surveillance that are now completely gone. And these are just two examples of how surveillance for AMR have just stopped to function during the COVID pandemic because they were unable to deploy at many sites because of the pandemic. Now, there are rules that we need to keep in mind that whenever we want to give antibiotic to a patient with COVID-19, we need to give it only for those who have the most severe presentations. If a patient presents with a classic CT finding and low procalcitonin, for example, which is something we are depending on as a biomarker, these patients really do not deserve to be treated with antibiotics. And if we are to give antibiotic, we really need to be guided by cultures. We need to reassess the patient on a daily basis and really not give prolonged courses of antibiotics, because that will lead to excess resistance. And there are many organizations that have put in recommendations on empiric broad spectrum antibiotic for COVID, and really stressing on the importance of limiting the use of antibiotics to those who are very sick, requiring ICU, and to be guided by culture. The National Institute of Health is one example. The National Institute for Health and Care Excellence is another example that lists criteria for when to consider bacterial pneumonia versus just viral pneumonia and when to abstain from giving antibiotics. I will not go over the WHO report because I think Dr. Balkhy will detail that in the next presentation, but just to say that WHO, as well as the Infectious Disease Society of America, the European Society for Critical Care Medicine, they all put guidance, not so much guidelines, but guidance to really strongly recommend against the excess use and abuse of antibiotics in the COVID pandemic. And I think this is my last slide to say that we need to integrate antimicrobial stewardship activity into the pandemic response. We need to educate the healthcare worker about the signs and symptoms of COVID-19 and when do we suspect a bacterial superinfection. I think in many facilities, if we reduce the turnaround time for COVID-19 testing, that will help making an early diagnosis of a viral infection and therefore convincing physicians not to prescribe antibiotic. We need to ensure continuity of essential health services and regular supply of antimicrobials, and exercise maximal caution in the use of biocides and really try to pick those that have less selection pressure for resistance, and ensure that the stewardship activities are an integral part of the pandemic and beyond. I thank you for your attention, and I think we're going to leave the questions till the end, right, Dr. Najwa? Najwa, you are muted, I think.
I was afraid my dog will bark. I have a little dog that she keeps on interfering with me. I'm very sorry. I was here very attentive. I was listening to you, but I didn't want the dog to talk. Or now you are hearing me? Okay. I'm glad to introduce our next speaker, and she's going to be talking to a doctor. One second. Dr. Hanan Balkhy, who is currently the Assistant Director General of the WHO Geneva. She will be talking to us today again about the subject of antimicrobial resistance, and her subject, we will be having it now. Impact of COVID-19 on AMR, WHO response. Dr. Hanan wrote a very nice article about that, which I urge every one of us to also look at it. Thank you. Dr. Hanan.
Thank you, Prof. Najwa. Thank you, Souha, for the great setting the stage. It's a great pleasure to be with all of you today, and I'd like to thank the Arab Public Health Association for this invite and for allowing us to bring back the life into the AMR agenda, which kind of got buried in a way with the COVID pandemic. And I'd like to, I'm very pleased to be here with all of you and with Prof. Khoja as well, a very dear and longtime friend and colleague of mine. So I'll try to address, and it's really nice to present after Souha, because you'll see how there's going to be a bit of tag teaming in the presentation. I'll try to just address again, going a little bit away from the human health perspective and how non-human health issues do affect us humans, and how do we need to be engaged in the overall agenda for a better health and life for us. The specific milestones led by the WHO, what are the national action plans and what do they mean? I won't go into deep with use, as Souha did an amazing job with that. A little bit about IPC and a little bit about the research agenda. Some of you might have seen the IACG report, but if you've seen many of the, some of the countries who have national plans, they actually start with something like this, a slide that actually shows the interlacing pattern of AMR and how it, where does it arise from? Where does it come from? We know that we're talking about resistance in certain therapeutics. So antibiotics become useless and they do not treat infections the way we like them to. The question is, why does that happen? If I say just one word about microbiology and pathogens in general, bacteria and pathogens, whether viruses, bacteria, but we're focusing a lot on bacteria today, they actually develop resistance to survive. So these single cellular agents, when they're exposed and put under pressure by antimicrobials, they change the way they can accept these antibiotics into the single cell. Either they produce enzymes that can degrade them outside of the membrane, or they change the openings in their cell walls so that these antibiotics do not enter into the cell, or they pump them out through efflux mechanisms. So the question is, if that basic concept that you understand, wherever there is mixing between antibiotics and bacteria, the bacteria become under pressure and start creating mutations. And those are the mutation genes that allow for them to resist the killing or the slowing down of reproduction by antibiotics. Another way of resistance arises from sharing these mechanisms. So then they start cheating and they give each other these genetic cassettes called plasmids. Some of them are amazing scientifically looking at them. They might carry up to 30, 40 resistance genes on one cassette. So if we look at this picture that you have in front of you, this mixing and sharing of antibiotics and bacteria genetic material, which we can also, by the way, uptake some of them through phages and loose genetic material in the environment, you're talking about within the human body itself, water and sanitation and hygiene, pharmaceutical companies dumping antibiotics into water bodies, the environment with water discharge effluent of humans and animals, the terrestrial and aquatic animals, food and feed. You can imagine spraying many citrus farms, rice farms with antibiotics. It rains, goes into the water, goes into the systems, plants and crops. So all of these issues allow for antimicrobial resistance to arise in multiple different environments. The bottom line is that we're exposed to the antibiotics, to the plasmids that carry the resistance genes, or to the primed resistant bacteria. And then when we become sick, us as physicians at the bedside have a hard problem finding the right antibiotic to treat. So the WHO, and I think these are the timelines, at least 20 years ago, I remember when I first was starting to initiate stewardship programs back where I used to practice, we were already talking about this. Actually, even when I was a fellow, talking about MRSA in the UK and those issues. The global movement of AMR started quite slow. However, 75 years ago, one of the 5 first mandates of the World Health Organization when it first started was to control the misuse of antibiotics. And I got to learn that a bit more recently. In 2011, there was, again, some initiatives, but I think the energy really picked up in 2015. So I'll focus on that past period, where the member states of the WHO came up with a resolution supporting global action plan and supporting countries to establish a national action plan. I'll talk about that in a minute. 2016, the United Nations General Assembly established the Interagency Consulting Group, of which I was privileged to be a member on. And at that time, there was also a clear endorsement by the 2 main partners, which now you understand why they are 2 main partners, the Food and Agriculture Organization and the Organization of Health for Animals, the OIE, and they endorsed the Global Action Plan, which meant that they will become partners in us as WHO addressing the dilemma of this existential threat of antimicrobial resistance. The IACG report was finalized in 2017. The tripartite assessment process started picking up, and the GLASS platform, which started a few years before that, became more strengthened. In 2018, we, as the 3 main agencies, wrote a memorandum of understanding on AMR and developed what is known as a work plan, which is shared among the tripartite and the member states that belong to these organizations. In 2019, the WHO established the Antimicrobial Resistance Division and elevated it to a higher level, for which I became the first Assistant Director General leading this new division. And it took me a while to develop the organigram and the elements that need to serve the agenda of AMR, as I will speak in a little bit. Within this division, we developed the Tripartite Joint Secretariat, which serves among the 3 agencies. And it actually, the report was given to the Secretary General. And we also developed a multi-partner trust fund, which has raised so far in the past year or maybe less, close to $13 million to work on multi-sectorial plans to be implemented within mid-low income countries to enable them to address this as a One Health problem and to make sure that they engage in a One Health and multi-sectorial work. So going into the national action plans, which serve the 5 major global action plan agendas: improving awareness and understanding what is AMR, strengthening the knowledge through surveillance and research, reduce the incidence of infection, which means IPC, infection control and biosecurity in animal and human health, optimizing the use of antimicrobials, which is stewardship, development of the economic case for sustainable investment to increase in medicines, diagnostics, vaccines. Each one of these needs to be looked at with a financial lens, and it also needs to be looked at in a multi-sectorial. As a simple example, antimicrobial optimal use, when I talk about that, I am addressing that, and I mean that from the animal perspective and the human perspective, and also from the agriculture perspective. So that is, again, another detailed discussion, but I'm happy to answer it during the discussion. But please find online the Global Action Plan, which passed the World Health Assembly resolution and also supported by FAO resolution and OIE resolution, as you can see on the bottom of the slide. Now, just having a national action plan, and I'm not sure if that's what Prof. Najwa was referring to, but as a previous director of the GCC Infection Prevention Control Group, I've worked with the amazing team from those countries and from within Saudi Arabia on developing the national action plan for the GCC countries. And we based it at the time on the global action plan. Since then, there's also been more technical advice and guidance from the WHO on how to support the national agenda and the national force work on this through developing multi-sectorial coordination guidance, global framework on monitoring and evaluation, and also on implementing coordination that came out last year. Again, being very practical and transparent, we were very keen on the countries writing their national action plan. We've developed a lot of support. The EMRO region has done amazing work, specifically Prof. Najwa with Jordan, and they're one of our model countries, to be honest with you, when it comes to EMRO work. I think several other countries as well have done an amazing job, and the support from the EMRO office has been crucial in doing this, as it is with many of the other regions in the member states that belong to those regions. So the positive thing is that national action plans did pick up a little bit, but the interesting thing is that implementation of the plans and finding funds for them has been the problem. And hence that's when we developed the Multi-Partner Trust Fund to push this agenda a little bit forward in certain countries that will need that kind of help. So what I wanted to say about the National Action Plan, that is we're still unfortunately at baby steps. It requires a lot of engagement. And you can imagine that it requires engagement at the multi-sectorial level, which means we need to engage ministries of agriculture, water, and environment, plant industry, and so on and so forth, and the private sector and civil society as well. The antimicrobial use, again, it's this was a mistake in the title. This is actually the section on surveillance. We talk about keeping the platform hot. How do we engage governments? Souha referred to the Jim O'Neill report, which is a little bit old now, but I think without, even at the global level, but these numbers and surveillance data is extremely crucial at the national and even at the subnational level. And because most of you are clinicians, I'll allow myself to talk a little bit on my experience at the healthcare facility level, which was extremely difficult to convince the strongest or the highest prescribers to abide by guidance if we had not shown them the MDRO data on the HAIs, if you will, and even on the primary healthcare clinic usage. So without data, without having proper surveillance, the AMR agenda will not move forward, specifically that data from the animal and human health as well. So the platform for glass, some of you might be familiar with it. It's the WHO platform, and it has in the purple some of the pilot phase additions to this platform. So it starts by applying to the glass platform. The WHO through the regional offices provides technical assistance to the countries on how to enroll. I have to admit it's not an easy task, but it's something that we're working on with a member state consultation early next year. And we're going into GLASS 2.0, and we're trying to add into this platform more easier ways to provide data on antimicrobial resistance, as well on antimicrobial use through surveys and point prevalence studies. We're also looking at enhanced gonorrhea surveillance. STI resistance is on the rise, One Health surveillance, antimicrobial use surveillance, and attributable death to antimicrobial resistance. And we're moving into the fungal issues, specifically with Candida auris almost becoming endemic in many of the organizations. Just to give you a flavor of the GLASS report, it shows you, it has a lot of data in it, and we classify it by high and mid and low mid-income countries. So antimicrobial resistance is not a problem only in high-income countries and where broad spectrums are used, but indeed in low mid-income countries. And you can see third-generation cephalosporin resistance in the slide and MRSA. And they've now become part of the Sustainable Development Goals in order for us to push the countries a little bit to give more attention, having it as an SDG indicator, which we succeeded to do so last year, will help the member states provide more attention and resources to this specific agenda. Again, cefepime, fourth and third generation cephalosporins, quinolone, and carbapenem resistance, as you can see. Again, I always have to inject my personal experience in this. In my opinion, the carbapenem resistance is much worse than what you see in this slide. However, you do see that the red dots on the vertical line is the range of the countries and where they can fall. So some of them are already hitting 80 and 90% in the cephalosporins, and also over 50% in some of the carbapenems. The antimicrobial use, again, maybe some of the overlaps with some of what Souha said, but I won't repeat what she said, but focus on the need of stewardship programs is extremely important. And the WHO is finalizing, by the way, guidelines, which is syndromic-based guidelines, disease-specific guidelines on antibiotic use, and that hopefully will come out within a few months maximum. But what we have done, and I think Souha did show this, where we gave more explicit language in the updated COVID guidance, because COVID has pulled behind it this AMR pandemic that is still silent, and we're not seeing much of it. And again, the data that Souha showed on the specifically on the global meta-analysis really is going to be extremely important for us to study and bring it to the higher on the visibility, if you will, and for us to use that in our advocacy purposes. We talk about also the Essentials Medicines List Antibiotic Guide, which is not a syndromic-based guidance. However, it does help the countries prioritize antimicrobials so that we can address the problem from the two parts of it. It's the overuse, but we have to emphasize very clearly that there are people who need antibiotics that are not getting it, or they need narrow spectrum antibiotics, yet they're getting much broader spectrum. So that's misuse. So in providing the guidance for the antibiotic list and classifying it into access, watch, and reserve, it's a way of saying that the list under access should be the more commonly used antibiotics, because they're more of the less extensive ones, the less expensive ones, maybe not as broad. And then the watch and reserve group of antibiotics are your ertapenems, your carbapenems, some of your quinolones, and so on and so forth. And it's to ensure and to support the utilization of this guide, which is on our website, is we're making a second SDG indicator that's pushing the countries to, when they measure their usage, that 60% of the usage is under the access group. We can talk more about that in the Q&A session, if you will. We have also monitored, and we're doing that on an annual basis. As you can see here, the guidance on the right-hand side, 65 countries, but this is just to show you how it's portrayed. And you can see that still the access group is not the most common one. Some of these countries have reached 60%, but some of them are still using the watch and the reserve antimicrobials when they should not. And this is, again, just a sample of 5 countries. We've established last year and finalized a very important toolkit to be utilized at the national and subnational level. We were delayed by COVID in rolling it out and doing enough, or what we were hoping for in country rollout of this specific stewardship tool. And again, this can be a presentation on its own, but as Souha mentioned, we need to look into stewardship. And again, I'm focusing here on the human side in this talk, but we need to look at it from the healthcare facility, primary healthcare perspective. But if it's not adapted at a national, subnational level, the support will not be provided. And without that support in allowing for enough infectious disease doctors or training of primary healthcare doctors, pharmacists who are core to the stewardship program, and educating everybody who has the pen and the right to prescribe antibiotic needs to be made aware of the proper methodology of prescribing an antibiotic. In infection prevention and control, one of the most dearest topics to my heart, The WHO has been doing a lot, had continued to do a lot. However, it's a topic that really requires major strengthening at the healthcare facility, primary healthcare, all the way up to national levels. The WHO response has been enhanced further to what they've been doing by their usual normative and regulatory and guidance role, specifically the guidance role, producing at least 12 technical guidance training through the platform of at least 1 million people, having IPC as part of the COVID R&D roadmap for the IPC agenda specifically, focusing on healthcare worker role and how to mitigate transmission of disease, specifically COVID in this context, which will also serve the purpose of transmission for other pathogens. A long way for us to go, and I'm happy to get into more details during the discussion. This is just to show you and to flash the collaborative role that WHO does with many of the other organizations, UNICEF, Global Fund, UNITAID, and Gavi, in providing these PPEs for the countries. Again, these are tools that need to be used by proper hands with proper education, and that's the role of probably the platform here and the audience in this group is how are we going to be training on using IPC? How do we enhance this career, create a career path for it, and give them the authority to lead and guide on proper use of PPEs and implementation of comprehensive infection prevention control programs. The research agenda for it, again, I'll leave this slide. I won't go into the details of this, but I think it's very important that what happened during COVID on identifying modes of transmission, we still need to understand the ESBL transmission, MRSA transmission, CRE transmission in the healthcare and community to better guide us on isolation policy procedure within the healthcare facility. My last 1 or 2 slides is on the AMR and the research agenda, and maybe Prof. Najwa alluded to this, but the number of companies exiting the R&D and development of antimicrobials is quite scary, starting from 2016 on this slide, but at least 12 pharmas actually left. Very poor ROI, inability to make enough profit to sustain this type of a business. So we've talked about this, and you can see it in more detail in our IACG report about certain incentives, pull mechanisms or push mechanisms, encouraging the pharma to engage further. And I think there's a lot that we can do in WHO to serve this purpose. One of the initiatives is to clearly help the pharma industry to prioritize the research. And we've created in 2017, not in need of update yet, still highlighting the critical priority pathogens as Acinetobacter, Pseudomonas, and the Enterobacteriaceae, but the high priority as well and the medium priority. This will guide the pharma industry on how to document. The link is provided to you at the end of the page of the slide. Also producing on an annual basis the preclinical antibacterial or antimicrobial, if you will, pipeline, where it showed that 145 entities, whether it's pharma or academia, developing at least 252 antimicrobial products. The guidance is, or this review is really interesting for you to read on how WHO with its partners and with its link of expert groups looking into guiding pharma, because this is going to be one of the biggest questions is we can't continue to use the same antibiotics for the animal and plant and human, because we're always going to be in that conflict of using antimicrobials to save economies because of the agriculture and food industry, yet salvaging those antimicrobials for human health. So the issue of innovation in developing antimicrobial agents becomes extremely important. That takes me to the next guidance, which is the clinical antimicrobial pipeline. So there's the preclinical pipeline and there's the clinical pipeline. In the clinical pipeline, so what of those in the preclinical jumped into the clinical pipeline? Out of the 145 or more or less 50. 32 of those agents are against high priority pathogens. Only 6 are innovative and fulfill the criteria of innovation, and 2 against the critical gram negatives. 32 for the priority pathogens, and 2 only against the highly critical or the critical antimicrobials. Again, we're hoping to update this on an annual basis. We also got into the business of giving guidance with this product, the AMR financial model. And again, this is not my comfort zone to talk about this, but developing to support setting up impact investment funds on new antimicrobials. Again, pull mechanisms on enticing the industry to get back into the business of developing an R&D for antimicrobial agents, and also a priority pathogen list for the fungal group of pathogens. This fits in the investment case. This is my second to last slide, where WHO played a major catalytic role in the creation of an AMR fund, action fund, with over 20 pharmaceutical companies, philanthropies, Wellcome Trust, Novo Nordisk Fund, and the European Investment Bank in pledging $1 billion to this specific industry, hoping to reach a minimum of 2 to 4 novel antibacterial treatments by 2030. So this is, again, something that we're happy, despite COVID, we were able to push it forward. This is just a slide to show you what I've spoken about previously, the MOU for the tripartite and the multi-partner trust fund, and the alliance that's been happening between WHO, OIE, and FAO. It's a very important alliance, and it's extremely relevant at the country level. With that, my last slide is, again, as you know, this is a very important topic. AMR is an existential threat to modern medicine. Without antibiotics, we can't go about doing our transplants, our cancer patients, but also antimicrobial business is extremely important for having access for those who are actually dying, specifically neonates and women, pregnant women who are succumbing to death because of lack of access to antimicrobials. And GARD-P, which is one of a spin-off from the WHO initiative, is really working on to some of these research agendas. Many other agencies are as well, with also prioritizing neonatal sepsis among this. Again, I apologize, there's really a lot to say, but that was my last slide, and thank you for your attention.
Thank you very much. This has been a very, I'm hoping, yes, you are able to hear me now. I'm not muted. Well, thank you for this very nice presentation and a real eye-opener. Many things happening, and I do hope that we will yet be able to do something about it. Now, I would like to invite our 2 panelists, Dr. Khoja, Tawfik Khoja, who is going to be, he is the Vice President of the Society, and of course, our Dr. Salman Rawaf, who will be joining us. Both of them are going to be panelists, and I'm sure there will be many questions that will be coming, I hope, from people online, so that we can address this issue further.
Professor Najwa, thank you very much indeed, and thank you, Professor Souha, thank you, Professor Hanan. I must say, I thoroughly enjoyed the presentations, and I hope we will continue discussing some of these issues. I noted so many things actually from the 2 presentations. I'm sure Tawfik did the same. And also, we received pre-meeting questions as well as questions are coming now. Before I hand over to Tawfik, I mean, Dr. Hanan, one of the most important issue of antibiotic misuse is mainly industrial and farming, both plant and animal, as you alluded to, but most importantly, even fisheries. So the magnitude of misuse outside medicine tend to be big. So is WHO focusing on that huge industry?
Am I muted? Can you hear me? Okay. Thank you, Professor Salman. A very important question. And that's why I wanted to highlight, I think you've seen in the slides, the focus of the tripartite. And really to put the numbers clearly, 70% of produced antibiotics globally, that's the estimate, is actually used in non-human sector.
Yeah.
That tells you how big this problem is. And I think the member states and WHO's leadership, Dr. Tedros was he's very passionate about this topic. And the Secretary General himself is extremely passionate about this topic. And I think in the IACG report, which I hope that you can take a look at it, and maybe the audience, the attendees can also take a look at it, it is a very important area. And AMR in the SDGs, it exists in specifically the health SDG, which is number 3, but it exists in at least 12 other sustainable development goals. And the countries need to address that. And that's where the challenge is that this is not, even though the audience today, I'm assuming, is mainly human health people, but the work that needs to be done in the non-human sector is extremely big. And I think I've alluded to the tripartite joint secretariat, partnering much stronger with FAO and OIE, enhancing this tripartite visibility at the country level, but then at the national and subnational level, this needs to be picked up in a very strong way. So it's a very important question. Again, keeping our vision even broader, when we talk about not just developing antibiotics, we need to start creating and separating what is used in humans and what is used in animals. Because for me, the producing antibiotics, it goes into this big sieve that has huge holes. I'm going to speak a few words in Arabic, maybe most of the audience is in Arabic, but we're going to put more antibiotics. If we don't create those control measures, we will lose them to resistance because of the nature of relationship between the microbe and the agent, which I spoke about a little bit.
But the question, which is actually from Jane originally in the UK, saying this, yes, we know the magnitude, but is it under control? Because we may be able to control some of the aspect in medicine, and I have a question to Souha on that, but certainly it is not under control on the industrial reproduction side.
Absolutely, I agree with that. And hence all of this activity that we're trying to do to bring it under control. Again, when you're talking about the usage in these different platforms, they need to be engaged with us to be able to address the problem.
But when a profit actually in the picture, Hanan, engagement is become a sideshow, you know, because if that is going to affect my production, you know, i.e. profitability as food production, animal production, fishery, etc., then God only knows how they will react. You know, this is a huge business. I don't know how to tackle this.
I think the tackling it needs to be by science. We need to show the evidence that this is harming us, and not only harming us, but harming the animals themselves. What I would like to advocate for is that when we say, yes, we need to save economies, we need to save people, we need to produce more chicken and meat and fish, right? But the problem is that antimicrobials are used for 2 main reasons. One of them is to compensate for poor hygiene. Now, poor hygiene does not only lead to antibiotics and AMR, but poor hygiene causes many other problems to the animals themselves and to the food supply chain, if you will. So it's really, antimicrobial can be used as the reason to improve hygiene in the animal health. And also, I have really horrible pictures. Antibiotics are used in the human health to compensate for poor IPC as well. So I think that's one of the discussion points that we need to start bringing to the table much more strongly.
Thank you. Let us move to the humans. So we come here, and I'm sure you will have some comments as well. But we got a lot of questions on the human side. But in a nutshell, and I'm trying to summarize it without mentioning names of the people who raised the questions, actually we have a generation of doctors who are not competent. That in a nutshell, because anyone misusing antibiotic, knowingly the risk, the long-term risk, you know, he or she is incompetent. What do you say to that?
Well, thank you, Dr. Rawaf. Can I just add a comment about animal and agriculture use of antibiotic, and then I'll move to the human use. I think I just want to give an example. For example, when the colistin resistance emerged in China and some other countries, immediately those countries reacted and put a complete ban on utilization of colistin in their animal feed and agriculture. So I think something can be done. So here in Lebanon, I take Lebanon, for example, we've had multiple studies from food, from poultry, etc., showing the MCR1 gene that is responsible for colistin resistance in E. coli. And yet you don't see any actions that have been taken to ban this product. So I think there are rules, there are regulations, the FAO, the WHO, the National Health Institute, they're coming with guidance and rules. And yes, in some countries, these rules have been really applied immediately. And unfortunately, in many countries of the Arab world, these rules are lagging behind. Now, in terms of human use of antibiotics, I tend to agree that this is something I use in my rounds with the fellows. I tell them the number of antibiotics and how broad spectrum they are is inversely related to the competence of the clinician who's dealing with the patient. Because sometimes what happens when your patient is sick, physicians panic and they tend to use the very broad spectrum antibiotic and multiple antibiotics at the same time. So yes, there is some truth to it. And there is also the confidence, because if you are a competent ID clinician and you go in a patient's bedside and you say, this is Streptococcus pneumoniae, and I'm gonna give penicillin, and you take responsibility for your decision, I think it takes some guts, but also it takes confidence and knowledge about the epidemiology, etc. A lot of the practicing physicians, they know nothing about the epidemiology of antimicrobial resistance in their country, in their hospital, in their unit. So you see that contributing to the abuses of antibiotics. Yes, definitely it does play a role. When I was in training in the US, my ID professor used to tell me the surgeons are using Cipro on all their patients because they know how to spell Cipro. I mean, it was a joke, but just to say that, you know, when you don't know what's going on and you become comfortable with a certain class of antibiotic, you tend to overuse and abuse it.
I mean, let me tell you something about this, because when we looked, I mean, I'm expert in health systems, so to speak. When we looked at countries with strong, for example, primary care, they tend to prescribe less antibiotic, you know, at hospital level, you know. And I was talking to Chinese delegation yesterday at a lengthy, actually virtual meeting about the system in China that hospital is attracting patients, minor and severe cases, all type of cases, because this is how they earn their money. I raised the issues of misuse antibiotic, and all of them accepted that actually, if we don't prescribe antibiotic, you know, patient satisfaction will be very low because we are under pressure from a patient to prescribe. On this, there is a question from Omar Dazai. He said, do you think there is a place, because this is very much linked for patient pressure, do you think there is a place for prophylaxis use of antibiotic in patient hospitalized for COVID-19? That's all of you. Come on. Souha, let's start with your clinical.
Yeah, based on the COVID pandemic, but also on our experience with many other conditions, giving prophylaxis, all it does is selecting for more resistance in the future infections that the patient will develop.
So there is no place for it?
In my agenda, there's no place for antibiotic prophylaxis in viral respiratory diseases.
Najwa?
Well, let me be qualified with that. The problem is this, and I think I have always been one of those who is always worried. We talk about the lungs as if we know what is in there. Unhappily, we really don't. And this has always been a concern to me. I know that maybe I'm an outlier and maybe I'm a little bit of a doubter, but whenever I see an infiltrate in the lung, I don't know whether it's bacterial or viral unless it is really obviously lobar. And so whenever we have that, frequently, in all honesty, because we're dealing with children, on occasion, I am guided by how sick the kid looks. And a sick kid will get unhappily from me, at least, let me confess, I will give the antibiotic, and if they don't improve within 1 or 2 days, I have to review what I have done. But really, the lungs, I think, I really wrote down now, one of the things that I find we haven't done properly is looking for diagnostics. We have to know what we are dealing with. And I really think, really looking at lung tissue, the nasopharynx, pharynx, so everything is open to each other. So really, whenever
you mean looking for diagnosis, basically for use of antibiotic is
or not, not only a culture. Whenever there is whenever you have an infiltrate, frequently, and I did a huge study, for example, in Jordan, where we did it nasopharynx and viral culture, and we had all kinds of viruses and so on. Yani, I never knew what is this organism ultimately the cause of the whatever we're finding in the lungs. Oftentimes we take it nasopharynx, or I think we should do much more diagnostic and much more science. Frankly, science I find is relatively lacking. From what I see.
Decision on suspicion only.
Yeah, science. We would like science that the pneumocyte is being infected. Then do something. I think it would be great to have that.
Dr. Hanan, should we use prophylaxis for COVID-19 patients which are hospitalized?
Yeah, that's very clearly stated in the COVID treatment guidelines that I flashed in my presentation. And for sure it's not, specifically for those who have mild to moderate disease. And again, like Najwa, the disclaimer is unless you're dealing with aseptic patients, then you're giving it prophylactically, not because it's COVID, because of sepsis. We don't want patients to fall into sepsis because we know sepsis patients need antibiotics early on, and we need to focus on what is known as de-escalation. It would be really nice to do a poll on this group on how many of them understand what de-escalation is and whether they do apply it. In the data that Souha showed, the initial presence of a bacterial infection among COVID patients was less than 4 or 5%. Those developing a secondary infection after being in the hospital didn't even reach 20%, if I remember correctly, I think 15 or 16%. And then 75% plus minus received antibiotics. And I'm not sure because I wanted to spend more time understanding how many of them underwent de-escalation. De-escalation means you start something, you stop, or you start broad and you narrow based on a specific pathogen. And the question is, of those 75%, how many underwent de-escalation? So antibiotics is not to be used for prophylaxis. In pediatrics, we use it for irritable, bladder, for people, there's very clear syndromes where we use prophylaxis for antibiotics for, and this is not one of them.
Professor Khoja, there is a question saying, I know you have set of questions all, but this is a question I know you would be interested in, from Professor Ali Abu Thin, saying Iraq already have extreme misuse of antibiotic. And same happens with COVID-19. It's a big problem in my country with no apparent solutions. Professor Khoja.
Thank you so much. Actually, I have two questions related to this question. Let me answer. First of all, let me thank the two professors, Professor Souha and Professor Balkhy, Hanan Balkhy. I remember now, I retain my memories with Professor Hanan Balkhy in the GCC. She was a leader of antimicrobial resistance and infection control in the GCC, and she published 2 documents, a very important document in the GCC, which is a reference until now. And also I'm pleased with Dr. Najwa, her presence in this very important webinar. I think the issue is very huge. It's not only Iraq, but Iraq, as it has been mentioned in the 2 excellent presentation, that it's an area where there is a lot of wars and there is instability, and also there is a lot of migration and displaced people. Also, the system is not in proper due to many reasons, and also lack of fund, lack of resources. This I think accelerate or propagate for the increasing of antimicrobial resistance and misuse of antibiotic and some malpractice in this area. So we cannot blame Iraq as a country, but it is the system, it's the whole issue. And this leads me to the question I'm about to ask: why we should always blame the doctors, the physician, for such issue? I think it is a multi-system. It is a multidisciplinary approach for such issue. We blame the doctors, and the doctors become frustrated. The physicians become frustrated that we are the creator of this issue. I think this is not right. So I would like to have your answer. Is there any strategic approaches to tackle the antimicrobial resistance from different perspectives, multifaceted? So why we are just, he's a prescriber, he's a diagnostic person, and he's a prescriber, but there is a lot of, there is a team. Where is the clinical pharmacist? Where is the infection control people? Where is the whole system? So I think to blame one person is not the issue. And I think because of this, we are still having increasing the prevalence of antimicrobial resistance, because we are dealing with the physician, where the real issue is behind the physician, I think. So this is one question. The other question related to Dr. Tahir also. What is the role of the WHO? The WHO has produced so many documents, magnificent documents. I read it, I enjoy it, I really love it in the diagrams, in the way they put it. But where is it in the undergraduate and postgraduate education, in all health institutions? I mean, I know antimicrobial when I finished my postgraduate, when I had the membership or fellowship. And I know it when I enjoy to be a leader in the GCC and as also a WHO temporary advisor. So where is it? Where is the essence, the rule of the WHO in the medical curriculum, in the healthcare institution curriculum, to enforce this issue? So this is the 2 questions. Is there a way to go a comprehensive whole approach rather than the physician approach? Second, where is the WHO role in the medical curriculum and health institution? So I left it for you. Thank you so much.
Thank you, Dr. Tawfik. I think if Hanan allows, I'll tackle the multidisciplinary approach and let Hanan tackle the WHO, since she's in the right position to do that. So yes, Professor Khoja, I fully agree with you. Whenever we speak about antimicrobial stewardship, we talk about a multidisciplinary approach. Everyone has a responsibility. It's not only the physician, it is the lab. You know, some laboratories release the full report of an E. coli fully susceptible and put all the antibiotic susceptibility, including carbapenem, 3rd generation cephalosporin, etc. Whereas other labs, you know, give selective antimicrobial susceptibility, so that if your isolate is very susceptible to the narrow spectrum antibiotic, they don't even release the result of the broad spectrum. So the lab has a role. Also, how quickly the lab issues susceptibility results. You know, there are some labs in the Arab countries where you can't get your culture susceptibility except after 4 or 5 days. So all this will allow the misuse of antibiotic. Obviously, the pharmacies have a major role to play, because in many countries of the Arab region, there are still countries and pharmacies within these countries that dispense antibiotics without physician prescription. So you can go to a pharmacy and request a box of ciprofloxacin or Augmentin or whatever.
Which means not controlled. There is no control.
No control at all. The pharmacist, the microbiology lab, the infection control, we can't stress enough the importance of lack of proper infection control into spreading antimicrobial resistance. There are many examples of outbreaks where multi-drug resistant Acinetobacter has spread in intensive care units because of lack of proper infection control practices. So definitely infection control also play a role. And I think administrations in the hospital also have a major role to play, because if they don't buy into a stewardship program and they don't support the stewardship program, the program will not succeed at all. So I think you are absolutely right. We are all believing in the importance of the multifaceted and multiple strategies and multiple stakeholders' involvement to really ensure proper use of antibiotics. So not just the physicians.
We will come to this point again, Souha. I mean, this is important. We need to share it with you and Najwa. What's about WHO? Why don't you control the way students are taught and doctors are behaving? And
thank you very much. That's a very good question, and the audience needs to understand. I did not ask Prof. Khoja to ask me this question. He did this on his own. So there's two parts to this answer. Number one is that WHO is not an academia up till very, very recently. WHO is an organization that provides norms and standards and guidance and regulation guidance. That's number one. I think people really need to differentiate and understand the role of WHO. Number two, we really don't have authority to go into and advise a country if they do not ask us. So we provide guidance, we provide rules and regulations, guidance, whatever. And then, as you saw, as a great example, which was the utilization of the access group of 60%, we published that guidance a while ago, but we would have no authority over any country to apply it. But then the tricky part is to make it an SDG. So then you have another body who's trying to say, okay, this is the goal that you have to reach. So that's number one. However, being an academician at heart myself, I think before I get to the academic part, so number two, what the countries need to do, we need champions in the countries. We need leaders in the countries who understand these problems and take these health agendas to heart and run with it. So what we did, as you remember, the core group of GCC countries and many other countries around the world, we were super passionate about IPC. We took the WHO guidelines, which are not supposed to be copy-paste, by the way. They're to be used to be transformed into national and subnational policy. There's a lot of energy that has to be done there. And you were with us at the table hearing those discussions. So we took those guidelines and created our own. And even within the GCC countries, as a model or as an example, we did it a little bit differently, although we were able to create one single reference as our IPC guidance. We didn't reach the point, or I wasn't there when I left about over a year and a half ago now, to do a stewardship one, which would have been the next step. So countries need to take the guidance from WHO, customize it to their local scenario, their local needs, and create their policy procedure at national, subnational level. Because I was there as well, at the national level, as a healthcare facility, I may not be able to take the exact national policy. I have to then recustomize it to my facility level needs. Am I a tertiary care? Am I a secondary care? Am I primary health care? And then based on that. But having that initial guidance out there helps countries move forward. When we come to the academia part, which it becomes very, very complex, the WHO has always done technical support and advice and then workshops. And again, the retainment of education in those is extremely minimal. What has also happened is creating websites like the MOOC sample and what I showed you, the WHO educational website, to create these short-term educations. You get a certificate, doesn't help with career advancement, does not help with CME maybe. But that's still an educational platform. Then the WHO Academy, established about a year ago, has now, maybe you have not heard much about it, has asked to pilot. We're going to be piloting 12, I think, again, don't quote me on the numbers. Several programs will be out there in the WHO Academy, which is funded specifically, I think, by France. And that's going to be a platform for education. And the AMR curriculum and education, if you will, which is not a certificate from a university, but it's from the WHO Academy, surveillance, not AMR as a whole, was accepted to be one of the pilot programs, and it's done between HQ, but led by the Euro regional office, and it's about surveillance education. What I'm working on now, and that's something that I'm very proud about, because we're working really hard on getting the initial steps of this project up and running, is developing an IPC curriculum that can be, in a way, a generic one. I'm not sure exactly how it's going to turn out, but we had to partner with educationalist consultant on that. And we're going to be working with focal points from the regions and academia to develop it. Now, when we do develop that curriculum, the universities now are going to be the stakeholders, not the hospitals. The universities need to take that curriculum, customize it. We will be offering something that's affordable, specifically for mid-low income countries. We're working with on that also with the expertise that has already happened, and maybe Prof knows that, the patient safety curriculum that's injected into the medical curricula, supported by the World Federation of Medical Education, which is an extremely important body that WHO is not commonly in partnership with. Right? We're in partnership with ministries of health. So this work that we're trying to do now, I think, if I may say, is going to be innovative, and hopefully it will work. And in developing a curriculum, again, because of my background as a medical educationalist, you will have a full curriculum, whether it's going to be an undergrad, bachelor's, or whether you want to do a postgrad, but it will have modules that can be inserted based on the needs of the different nursing, RT, therapists, medical, and then the subspecialties. Sorry to take too much time, but I just wanted to.
That's great, because next week we're talking about medical education related to this. I'll raise it.
Very good.
Maybe we ask you to join to contribute. But I think let me share with you an experience, because prescribing is a subconscious process. You know, people sometimes prescribe without noticing whether they are over prescribing or under prescribing. And what I did, and it was a lovely exercise when I was Director of Health in South London, we monitor prescribing of all GPs. We do that. We used to give them feedback about their prescribing of antibiotic. Within a couple of years, we managed to reduce the prescribing by about 70%. It's a beautiful data. We have a nice question from Wasan Jalad. What do you advise, because our meeting is about COVID, what do you advise as the first line of antibiotic in COVID patient with GI symptoms?
So,
carry on, Souha.
Yeah, so COVID with GI symptoms at the beginning of the presentation, that's a COVID viral infection causing diarrhea. We advise symptomatic treatment to increase hydration. If the diarrhea is very bad, we give them anti-motility. But I would not give antibiotics to diarrhea in the setting of COVID. Not at all. Not at least in my practice, and as I've discussed this with many colleagues from European countries and the US, no one is prescribing antibiotics for diarrhea due to COVID. Just
that's what I know. Najwa?
Doesn't antimotility might have a harm for them? The virus will hang around the GI tract for a longer time. I mean, really, why should you give them antimotility? What's wrong with just fluids?
No, I mean, if they're very bothered, I had an elderly patient who said, I went to the bathroom 7 times and he was getting dehydrated. I don't have a problem giving antimotility when it's a viral infection. The problem is more significant when we are thinking of Salmonella, Campylobacter, or Shigella. But for sure, I don't give antibiotics for these patients.
I don't know.
You disagree? Come on. Let us hear it, because our audience are interested in COVID and treating COVID patients, especially with the escalating number of cases across majority of the countries in our region.
Can I just add that there is a subset of severe infection that has led to ischemic bowels, etc. So of course, depending on the age group of the patients, so I don't deal with diarrhea in a 20-year-old the same way I did with diarrhea in a 75 or 80-year-old patient, where you start worrying about ischemic bowels, especially if it's a bloody diarrhea. So I mean, in both scenarios, they need to be assessed and decide what are the measures. But
will the culture help?
But no, I mean, there's no data at all so far that these patients have superimposed Salmonella, Shigella, or Campylobacter. On the contrary, we're seeing more Clostridium difficile colitis in COVID patients who receive antibiotics. So for me, no antibiotic in diarrhea and COVID.
With diarrhea now, we of course have these new molecular methods which are beautiful to diagnose diarrhea very quickly. And maybe that would be a time when you find what you have very quickly rather than prescribe antibiotics or whatever.
Actually, on this, we have comments from London, from David, saying diarrhea is one of the symptoms of COVID patients. Sometimes it's the only symptoms. And so far, we believe antibiotic is not indicated. Hanan, any comments on that?
No, I totally agree. And I think you see that
diarrhea and antibiotic for diarrhea in COVID patients.
No. Again, I'm a pediatrician, so I agree with Najwa about maybe the spectrum of patients we're talking about. You're talking from neonates all the way to Souha's clientele, if you will, the elderly. So again, antibiotics is not an antipyretic. It's not an antidiarrheal agent. Unless you have really good basis for using antibiotics, we do not use antibiotics. I want to just add, I know we only have 3 more minutes left, but I think to the previous question that Souha answered very well, and you were talking about, the clinicians and how competent they are. I think the physicians and the young trainees, and that's what I would used to do with my residents and trainees, they need to be the head of the ship. In managing a patient, one person is accountable for the patient, in my opinion. I don't know if you guys agree with me, but the physician is the accountable person. And that physician is responsible to be trained to lead the clinical management of his or her patient. And I can tell you that some of the decisions on antibiotics are based on risks of patients in the hospital specifically who are instrumentalized. Central lines, bladder catheters, IV cannulas, arterial lines, and whatnot. And we did, I think this was, I don't know if it was published, but if you ask physicians how many of them know whether their patient has a bladder catheter or not, some of them don't even know. And to me, this is not a comprehensive physician approach. If I'm the doctor of the patient, I need to know everything about my patient, because sometimes antibiotics are given I'm going to give it, especially in certain ICUs, I'm going to give it till I remove the chest tubes or till I remove the bladder catheter or. So again, I think if the audience here specifically, we're focusing on young doctors and how they think, I think understanding the patient's scenario from A to Z is extremely important, and making a decision based on a diagnosis, whether it's a clinical based diagnosis or a laboratory based diagnosis, it's very important.
Okay, but that's leading to a question, which I was looking at it here, leading to a question, which is, I think, is a bigger question. We cannot cover it in the last minute or two. Is there any room for prophylactic antibiotic quick answer from Hanan.
Of course, I alluded to that. Again, as a pediatrician, there are certain scenarios where we have antimicrobial prophylaxis is given in endocarditis patients, for example, in mitral valve disease. It's given in patients who have, again, maybe I'm a bit distant from the clinical perspective, Najwa can answer better, certain irritable bowel bladder syndromes. I had a patient who would come in repeatedly.
So it's limited in number, very limited.
It's very clear when we would give it, and it's not a subjective decision that you give. It's still based on guidelines and guidance.
Najwa, you said no?
No, not for COVID. I thought you were asking about COVID, but definitely, for example, let's say in rheumatic fever, everybody knows you give prophylaxis. Everything has its place. I really think that clinicians should be given more power to think for themselves at times. Frequently, we think the lab at times tells them what to do, and this I also resist.
Thank you very much indeed. I'm really grateful to you all. Thank you very much, Professor Najwa, for your leadership. Thank you very much, Souha, for the lovely presentation and discussion. And Hanan, Professor Hanan, I don't know how to thank you. We are extremely grateful to you for your leadership at WHO, or for being with us. And we are extremely proud of you. On behalf of Professor Khoja and all members of the Arab Public Health Association, thank you very much indeed. Next week, we'll talk about medical education. Hopefully we have WFME with us. We have Professor Pinder from Imperial College, and the Dean of one of the medical school in Egypt. We will tell you all the names and the details shortly. Thank you very much indeed. Good night.
Thank you. It was a pleasure. Thank you.
Bye-bye for now.
My pleasure. Thank you. Bye-bye.
Thank you very much. Thanks.